Okay, good afternoon and welcome to our third session on the second day of our Connecting the Dots series. So today's session, we're going to be speaking on pain management, right? So we have with us at the moment, Dr. Dale Ventour. Dr. Ventour is going to present us on pain management in hemoglobinopathies. Let me just tell you a little bit about Dr. Ventour. Just a second.
In the meanwhile, please remember you can use the Q&A feature or the chat to post questions. After Dr. Ventour's presentation, we will have his Q&A session before Dr. Smith. All right, so.
If you could pull it up now, I'm not seeing it.
Or if we could allow Dr. Ventour to introduce yourself.
Okay, yeah.
Sorry about that. Dr. Ventour?
Yeah, can I go ahead? I see Dr. Smith's logging in. Hello, good afternoon, everyone. Thanks for the kind invite. Currently, I'm a consultant and lecturer with the University of the West Indies, based at Eric Williams. I'm a dual accredited consultant, both in intensive care and anesthesia. And I interact quite a lot in terms of HDU care and pain care within the hospital for a lot of patients, especially those that have more chronic pain syndromes, for which the hemoglobinopathies come under. So I'm just going to share some local experience in terms of managing pain within the hospital setting. Okay, let me get this. Okay, so, all right. So my talk this afternoon will be on pain management, really local pain management in hemoglobinopathies. Namely, I'm talking about sickle cell disease predominantly, as that's associated with a lot of, can be associated with a lot of pain. So the talk, I'm just gonna define what, I just have to mention a bit about what we classify as patients with chronic pain syndromes, so that you have some semblance of, it's not a labeling, but you understand that it's a distinct entity in terms of medical management. I'm going to talk about the acute pain crises and episodes that patients with primarily sickle cell disease present with. I'm going to discuss the principles of management, that the endpoints that we both the practitioner and the patient we try to come to. And then I'll go through general pain management modalities that we use for patients. Okay, and I will mention a little bit about the new therapies that are on and new therapies that we use in terms of in the armamentarium of dealing with pain. So what is chronic pain? So the reason why I say sickle cell disease comes under this umbrella is that in general terms, it's experiencing significant pain for most days for more than 4 to 5 months. So we say 6 months of pain for most days. We classify this as someone having chronic pain. Now, the reason why I have to make a distinction is that chronic pain carries with it a few things in terms of the whole psychological component, which is quite significant. And that differs it from the acute pain. So the acute pain being something very finite, it's there because of some issue with an organ per se. So in the sickle cell case, in a patient who has altered perfusion or blood flow to that said organ, and it's really a cry of the organ in terms of having ischemia and possibly death, because if you cut the blood supply to anything, it will die. So it's two separate entities. So it's acute pain, and then there's chronic pain. So the acute pain can lead to chronic pain, which is something that I want to highlight, in that you have to get adequate pain control in terms of your, when you first present. So that sort of decreases your risk of developing chronic pain syndromes. If you have a factor that contributes a lot to developing chronic pain syndromes is poorly managed acute pain. But I'll get onto that in terms of in the next slide. So chronic pain is a significant problem, affecting more than 1/3 of the patients with sickle cell disease. And as I said, with the acute pain, you get a psychological response that's quite finite until you control the pain. But having this happen repeatedly or having poorly controlled pain adds a psychotropic component to the presentation. And you find that patients who develop chronic pain and chronic pain syndromes tend to have a lot of anxiety and depression associated with the whole physiologic response of having pain, you know, such as the cardiovascular stress response. So this winds up and makes the whole entity of chronic pain more significant if is poorly controlled acute pain. So why do sicklers or people with sickle cell disease develop pain? And the pain entities are quite different in terms of the subjective field. So patients present with acute painful crises, which can happen in any viscera, in any organ, as a result of the pathophysiology of the disease. Patients could have bony pains, which tend to be quite debilitating, very painful, and in non-specific, in generalized areas. So it's not, it can be localized, or it can happen in a more generalized way if they have in multiple marrow infarcts. Vaso-occlusive crises, just like when I described, is if there's an alteration or cessation of blood supply to any organ. This is all part of the response of the organ responding to lack of oxygen and thereby lack of function, and this further leads to organ death, organ demise. Acute chest syndrome, again, associated pain in a localized area. And this pain is quite significant because it affects not only because you have oxygen diffusion issues within the lungs, but you also get, because of the whole vaso-occlusive phenomenon, you get a lot of pain when the patient tries to take a deep breath, which further compromises their respiratory function. So if you have compromised respiratory function, you have compromised oxygenation, and you get more sickling, and it's a self-fulfilling prophecy in terms of how it spirals. And organ ischemia. So these are the main ways that patients present with pain. People with sickle cell disease could present with all, they could present with 3, they could present with 2. So what it helps us clinically to delineate is the location of where the event is happening, and it helps us to, because we know the general area of where it's happening, we could clearly define what sort of crisis you're having, and we could decide, we could follow up in terms of knowing well-recognized complications of occlusion in whatever area it's happening. So pain is a very important symptom, but it can be quite debilitating. So that's the big take-home message in terms of pain relief, of pain management in these principles. So what we try to do, I think the bottom line is, sickle cell disease is very peculiar. It's very important that you, just like with all other pain episodes, you have to find out what the underlying cause is. Because by not addressing the underlying cause effectively, you're just predisposed for recurrence of pain. And subsequent pain, it winds up the whole pain pathway, and subsequent pain is a little harder to manage. One, because psychologically you're expecting the pain to be bad from previous experience. And two, you also intrinsically have a sort of wind up in terms of your nociception or your pain pathways within your body. And these things contribute to making the subsequent episodes worse and making the patient head towards them having a sort of chronic pain syndrome, which is very difficult in terms of getting existence and being able to function in society, etc. So it's very vitally important. So patients, they need to, with experience, keep away from their triggers. They need to concentrate on their hydration, proper diet, supplementation. For those who have frequent episodes, despite doing all the right things, you could look at disease stabilization with hydroxyurea. I know it's unpleasant for a lot of people, but if you could stabilize the disease a bit and give yourself a little leeway in terms of resetting your pain scores and your management of your disease, then it's always a good idea. Optimizing your hemoglobin and focusing on diet. And very importantly, especially early on in the episode, is trying to get adequate pain control. So the adequate pain control comes simultaneously with treating our underlying cause and getting the patient settled in terms of having an underlying cause. So as part of the initial treatment, high up on the ladder, high up on the plan in terms of the management plan is adequate pain control, while you optimize everything else, as I outlined before: adequate hydration, optimize the hemoglobin, treat any infections, all the precipitants that could trigger the sickling crisis. So that's the most important part of the whole thing, is stabilizing disease, because as I said, pain is just a symptom of the underlying pathophysiology. So you want to control that symptom as best you can going forward, rather than focusing purely on pain management. Because if you don't sort out the underlying cause and optimize the underlying cause, then you just have a pathway onto developing a chronic pain, a chronic pain syndrome. Okay, so what do we use? So the cornerstone therapy is non-steroidal, such as ibuprofen, diclofenac, naproxen. These are especially good for bone pain. They're very potent, and they're very helpful. Now, the way that you go about dealing with your painful crises, simultaneously, again, I just reiterated what I'm saying. You optimize your fluids, you optimize your temperature, you optimize, if you do have, burning in your urine, or you're developing a fruity cough, that needs to be sorted with some intravenous antibiotics. So while you're simultaneously doing that, you need to be addressing the pain very aggressively. So what that will mean is, yes, you start with your first line, especially if it's bony pain with non-steroidals, but nothing comes for free. Non-steroidals have quite a big side effect profile. And you potentially, that's why I say short bursts, a few days, because what you want to do in that time is get your underlying issue sorted, and you want to get into using other modalities. So the approach would be multimodal, meaning many different drugs working on different pathways in order to address the same endpoint, which is alleviation of the pain. So you also start with your paracetamol or acetaminophen. I think that has the lowest side effect profile once you take it regularly every 6 to 8 hours, and you take it regularly for with your non-steroidal. You have them working simultaneously, and you try to overlap the dose. So you don't take both at the same time. You try to stagger it a bit so you have coverage for the day. So we start off with paracetamol, non-steroidal, specifically if we're talking about bony pain. And as I said, you have to absolutely stay well hydrated, because the non-steroidals could damage your kidneys if you take it for a prolonged period and you're dehydrated. The non-steroidals can interact with other drugs that could make you, again, damage your kidneys. So you have to be very careful in terms of drug interactions. But the interaction of non-steroidals with paracetamol is pretty benign. Then we add, for more severe pain, we add tramadol. Tramadol, it's an anti-serotonergic drug. It blocks descending pain pathways. And it also has some weak opioid effects. So weak effects like morphine. So used in combination, there's a combination drug called Tramadol, which is tramadol and paracetamol, and that's your second tier of pain relief. So that's if you have moderate to severe pain, you use your tramadol. So bony pain, first tier, paracetamol and non-steroidals like ibuprofen or naproxen. Then your second tier, you're going up, you're using your weak opioids such as tramadol. And you, as I said, you could use them together. So you use them together, you hit hard, you get control, and then you start to back off the drugs. Now, nothing comes for free. A lot of side effects for tramadol, such as drowsiness, constipation, you get a bit of dry mouth, nausea can be significant in certain percentage of the population. So these are the side effects of using these strong painkillers, and they are strong painkillers. But as I said, your goal is to get quick control, A, so you could continue mobilization, and B, so that you could start to focus on the other parts of your management. Because if you have pain, it's all encompassing, you think of nothing else but alleviating that. So you just have to go in, hit hard, and get control while you're sorting everything else out. And then you could source some codeine. It commonly comes combined with Panadol, so something called Pathadine. Just remember that the combination drug, you can't use paracetamol or acetaminophen separately because there's already Panadol. So you could overdose on Panadol, yeah? So all the combination drugs, such as Tramadol, you use alone without paracetamol. And if you use Pathadine, you use that without paracetamol because it contains paracetamol. So you have to just beware, look at the label, make sure that you don't have any extra acetaminophen or paracetamol that you're using. Right? And then for patients with quite severe pain, you could go to using morphine and morphine-based drugs. But you have to be very careful. And rightfully so, it's prescription only. Rightfully so, it's for the shortest period of time to get control. More commonly for us to use in hospital in terms of us getting acute control because of the risk of the morphine being abused outside, meaning that the drug is hanging around. You don't want some other family member using it because of the side effect profile. And also this drug has a lot of side effects such as drowsiness, nausea, vomiting, constipation. So it comes with a lot of side effects. And remember, you're adding side effects from the other tier of drugs with this drug. So this is the whole issue with the use of morphine prescribed outside. I'm talking about oral morphine, and that's the issue. But it's good for short runs, get acute control, and concentrate on the other things in terms of getting the care that you need. Also, for patients who are having frequent episodes or quite debilitating and severe episodes, we have drugs that also modulate your response and it modifies your perception of pain. So tricyclic antidepressants, because what you find is your pain is usually worse at night. When there's no one around, it's just you and your pain, and that's where you have the worst pain, is usually late at night. And as I said, the longer the pain issues continue, the more likely you have concomitant anxiety and depression associated with it. So the tricyclics just help you to, even out mood, help you get some rest at night. So keep your circadian rhythm going well. And if you're well-rested, a well-rested body and brain, you can function a bit better to battle with the discomfort you have the following day. So these are adjuncts that are used in order to modulate the pain. Now, what you will see here is that all these drugs that we use, because of the side effect profile, you want to limit how long you use these drugs, because nothing comes for free. All comes at a price. So then you might ask, what are some of the non-pharmacological things that can be done? So physical therapy is quite effective for, and that's a type of massaging and movement of affected limbs in terms of facilitated movement and touch therapy and massage therapy. Acupuncture has been shown to work in terms, but it works on a percentage of people. So it could work up to 40% of patients in terms of direct pain alleviating properties. For back pain, vertebral infarcts, we use the transcutaneous nerve stimulation. It's a little machine that gives a pulse, and that electrical stimulation seems to alleviate pain a bit. And but it has to be localized pain in some area. Is quite effective. Hypnotherapy has been shown to work in a percentage of patients. And cannabinoids, this is CBD. This more modulates your pain and regularizes your sleep-wake pattern. And again, it works on a percentage of patients. It doesn't work for everybody. So these are other modalities, but these modalities tend to have fewer side effects. And what you need to be doing is chop and changing, you change another one, you try something else, so that you have, because the sicklers are quite good at knowing their pain. So they will, most sicklers could differentiate what pain they're having in terms of whether this is bony, whether this is just a dull ache that they think it's just precipitating from some splanchnic ischemia. They tend to know. So you will have to know what works for you and what works for you in your specific situation, so that you could have this going on the background while you're getting your pharmacological control. Now, what is the other issue is, if the pain is out of what your accustomed norm is, as bad as you might think it is, you need to get medical attention. You need to seek medical attention. Reason being that there is some underlying process occurring that's precipitating this. And the very difficult situation is that you stay at home thinking you have it under control, knowing to yourself that the pain is way out of what you're accustomed doing. Because the problem is, by the time you come to hospital, you're really wound up in terms of analgesic requirements. More than that, in terms of organ damage. So the whole focus is trying to find out the cause, sort the cause out, and trying to limit the amount of death or dying organs that you have. So that's more important than all the modalities that we go about trying to get pharmacological and non-pharmacological. But as I said, they overlap, they interact. Your pain relief needs to overlap, and you need to use non-pharmacologic as the backbone to get you through the episode that you're experiencing. Okay, and they use interchangeably with one another. Okay, so it's not very difficult in terms of pain management. There is a big education issue in terms of the medical fraternity appreciating the significant pain that sickle cell disease have. Generally, you find that doctors are a lot more sympathetic with the pediatric population. That's just been my observation, but I think everyone has to be treated very aggressively in terms of getting adequate pain control. All right. Okay, so any questions? I think I see something in the chats.
Yeah, okay. I'll ask Alexandra to take somebody, read some of the questions.
To read some for you?
The questions.
Yeah. So I'm seeing the questions here.
Okay.
If after taking the tramadol you throw up, do you have to take over the dose? So what I will say is, if you take the tramadol and you see the tablet, yes, by all means, you have to take a subsequent dose. But you have to remember that two things cause pain. Two things cause nausea and vomiting. Pain is one, because if you're in enough pain, you feel sick, you want to throw up, and tramadol on its own causes nausea and vomiting in a percentage of the population who metabolizes it, who are fast metabolizers. So for that reason, what I will say is, if you're nauseous, you should try to get maybe some an antiemetic in, such as something PR, as per rectum. So there's no issue with you throwing everything up, because it's sort of pointless if you're retching and vomiting to try to give you oral meds. You just keep vomiting the meds out. Get the nausea to settle. And I wouldn't go for tramadol then, because that is, it can cause quite a lot of vomiting. So if you use another painkiller to give you some relief, and then if you want stronger pain control, because I presume you're taking in tramadol because nothing else has been working. So you get something to give you a little baseline. So you take a paracetamol, your non-steroidal, your pain gets a little better, but you know you have quite bad pain. Then you could time to get a tramadol. It will more likely stay down. But you have to know that tramadol on its own causes more nausea and vomiting than than all the drugs that we put there. So it can cause you to feel sick. So that's when I will say you could actually try something like codeine instead to see if that agrees with you a bit better. Okay. Right.
All right. Someone asked, Doctor, can you define and talk about the usefulness of pharmacogenetics in the management of all types of STD pain?
Yeah. So I just described one pharmacogenetic, and that's the metabolism of tramadol. There's also pharmacogenetics in the metabolism of codeine. It's a specific enzyme you have different parts of the population that are fast and slow acetylators. So what you need to do is you ignore all that. You just have to try and see what works for you, because what works as a pain regime for a specific person may not work for another person. So you just have to get to know what your body will tolerate in terms of metabolism of the drugs that I outlined. So there's no big genetic pharmacogenetics when we talk about acetaminophen or paracetamol. That's more or less steady. But when you start to go up the tier in terms of your stronger painkillers, there is a big pharmacogenetic. Big pharmacogenetics plays a big part in terms of alleviating pain, right?
Okay, so someone commented that you could use gravel to aid with the side effects, with some of the side effects of the tramadol.
Yes, but the question is how you're taking the gravel. So that's what I was saying, that the best route is actually PR, per rectum, because you can't vomit it out then and you'll get the effects. Taking a gravel tablet when you're sick, you just throw it up, it's pretty tricky. Okay. So in terms of getting your absorption. So that's the issue with the nausea. And the other issue is the two things that cause nausea. Pain on its own causes nausea, and the tramadol and the stronger drugs do cause a bit of nausea.
Someone has a question. If tramadol is offered at the A&E and you tell them it doesn't agree with you, but they insist that's what you're getting, what to do?
So all you need to tell them is, listen, I get severe nausea, even with gravel, because they will tell you they're giving it with gravel. But you have to be clear that the tramadol really, doesn't work for you. Because what you have to understand is that the pain relieving factors are not just one pathway. And in order to get adequate pain control, you have to work on a lot of pathways in order to get control. So it's just not one way to reach your point B, but there are multitudes of ways to work for it to work. So that the tramadol works on another pathway, which is, as I said, the descending serotonergic pain pathways. And why you might think it doesn't work, they will be putting it as part of a big cocktail in order to tackle the pain relief and stagger the pain relief so that you don't stay without any pain relief for any period of time. You follow? So it's vitally important how you administer the drugs in terms of the timing. If you give all your painkillers at the same time, you will be in pain because there's no overlap of pain relief. Okay? Yeah. And they have different half-lives, they last different times. So the more that you tackle, the better. So what I will say is, if you could take the tramadol and tolerate the tramadol, it will be working on your descending pain pathways. They're supposed to be assessing your pain. So you say there's no little or no change after 20 minutes or half an hour that the drug works. Mm. And then there's no reason why they can't give you another or other painkillers, which they should be doing anyway.
Okay. But based on my experience,
Yeah.
They don't.
Yeah.
If it is they administer tramadol, you have to wait the whole 4 to 6 hours unless you are complaining, and then they will give you the morphine or the Pathadine.
Right.
That's why I wanted to ask Dr. Ventour if your recommendation say if this is an established protocol that is used in the hospitals.
It's not established protocol. Now, in the hospital, just like in the public, there's a big phobia, a big fear of morphine. There is a morphine fear. And I grouped the morphine and the Pathadine in the same group of drugs, right? So Pathadine is not as potent as morphine. It's about a half to a third the potency of morphine. Yeah, morphine is the big boy. But the problem with the morphine, as I told you before, is that its extensive side effect profile. Now, everybody just concentrates on this dependency. Now, if you're in acute pain, dependency becomes less of an issue.
Exactly.
But the side effect profile is massive. And the side effect profiles are respiratory depression is what we're afraid of, that you have a respiratory arrest, because a lot of these drugs work together. So while you might be comfortable, you won't breathe. So that's the issue about co-administering the drug, and why it's not an issue for us in my field, in my area of work, is because I have good monitoring. You know, we're in the critical care, we're in the HDU, people looking after you, they're looking at your vital signs, we're assessing. But everywhere else, they're very, very twitched. That's the healthcare workers about administering morphine, especially using morphine with concomitant weak opioids, you know? So that's
On that note, I've heard some hematologists abroad as well as locally swear against using Pathadine because of the dangers of, as you mentioned, the side effects and the long-term damage to kidneys and so on. But it's widely used here. And some patients, that is the only thing that works in a crisis. So what is your opinion on that?
So my opinion is you get the pain relief you need. Whatever works for you. You get the pain relief because the effects of having pain is so all-encompassing. I don't think you could move forward in the management at all if you don't address the elephant in the room. So whatever works, you get, but it takes a multimodal approach, meaning that it's just not Pathadine alone. You need to have overlap, other pain reliefs, overlapping with the time so that you could have continued analgesia for the day and not just in bouts where you feel comfortable and in 4 hours or 6 hours you're in absolute agony, then you get a bolus. That's really poor control.
And that's exactly what happens here.
Yes.
It's exactly what happens.
So the issue is that, yes, it's just to let you all understand what the fear is with the practitioners administering. Now, in your population, it's not a big problem because people tend to be young, but in the older sicklers or the older patients or patients with comorbidities who have a bit less reserve, it becomes more of an issue because of how they metabolize and the cross interaction with other drugs. So yes, you're right. They are a lot happier administering tramadol because the honest truth is you need a lot less monitoring than if they give you a strong opioid. Pathadine, as an anesthetist, it's a pretty rubbish drug, but you know what works for you. You know, I've not used Pathadine in probably 15 years. You know, I deal with morphine. That's all I deal with, and I deal with fentanyl, which is I wouldn't get into that, but fentanyl is an anesthetic drug. But I deal with morphine. You know, so
That's the thing. You listen to your patients. It's the same thing what you were just saying. We know our pain.
Agreed.
Doctors here, they refuse. They think that you are telling them how to do their job.
Agreed.
But it's not that. I'm telling you what works for me. The faster I get out of here, it's better for you.
Agreed, agreed, agreed.
But that is not the consensus here at all. The doctors refuse to listen to you.
I know, and I've been
and they never think you are in much pain because your threshold is so high.
Yes.
So unless you're rolling on the ground bawling,
yes,
that's the only time they will take you on.
Yes. Agreed. And again, it comes with education on our end. I mean, that's in you know, A&E is on the wards. If you think the A&E is bad, they're worse on the wards. So that's the thing. Yeah, it's education.
Yeah, Karen. You started when you started, you identified early on that patients who live with chronic pain have issues with anxiety and depression. So would you suggest then that persons who live with chronic pain should also be co-monitored by a mental health person?
I don't think they should be co-monitored, but I think they should assess assistance.
Mm-hmm.
It might just be a bit of counseling. It might just be some behavioral therapy. It just might be, you need help because that component is very significant, especially if you have this pain for such a long time. It wrecks your life, just to cope. It's horrendous and we underestimate it. And a lot of times patients say, I could cope, man, I could cope. But you can't cope with this. You need to get some help, some intervention in terms of helping you cope with that issue. Because at the end of the day, when you develop a chronic pain syndrome, you have to be very clear in terms of what your endpoints are.
Yeah.
You're not going to be pain-free. I'm just making that clear. Because you've already psychologically, it's all embedded. You understand?
Yeah.
So the goals need to be how you will have your good and bad days. Your goals need to be functionally what you could do. You need to have goals about what pain relief you use in order for you to be functional. And so you see, the whole talk when we're talking chronic pain is totally different than when we're talking about acute pain. Acute pain, you're trying to control your pain, deal with your underlying problem, get you home. That's not what we're talking about with chronic pain. It's totally different. With chronic pain, we're trying to get you to cope with life, to live being in pain. So it's quite different. It's day and night. But I keep saying that in order for you not to progress to that, there needs to be more control in terms of the initial episode and flare and disease control, whatever you're doing to control the disease. So there's some onus on the patient, the person, to control their disease. And there's a lot of focus on the medical fraternity to help you through your acute episode. Because you have to remember—
Does acupuncture work for bone pain?
Yes, it can. It works for bone. It won't work for generalized bone pain everywhere, but I know it's been very effective for upper limb pain, for generalized pain. I've seen it work in unilateral lower limb, but you also use it. You have to remember that it's one of the many techniques. So you try it if you with a flare, and then you know that you use use it in conjunction with your other oral drugs, and it should shorten the time that you have it and help alleviate some of the pain. As I said, it works on about 60% of the patients, just like your hypnosis. You know, it doesn't work for everybody.
Go ahead, Alexandra.
Okay. I'm seeing someone says, can gravel damage you in crisis treatment? It has been withheld.
So the reason why the gravel is withheld is because when you co-administer Gravol with an opioid, such as morphine or Pathadine, or even tramadol, in anticipation of the patient being sick or being very sick with it, Gravol makes you drowsy. So that, in conjunction with the drugs, increases the amount of drowsiness side effect. And being drowsy and in pain is awful. It's an awful thing, you know. So you have to be careful. So sometimes they won't give it if they already loaded you with a lot, or they gave you some tramadol and they want to give you a bit of morphine and you're not sick. They will hold back the Gravol. It's mainly because of the drowsiness. So that's the downside with giving Gravol.
Okay. There's another question here. Do body pain receptors increase with extended use of opioids?
No. So yes, I think the person's trying to bring up something called tolerance, meaning that you need a higher dose in order. So there are two things. So there's dependence, which everybody knows about, meaning that it's a psychological thing in terms of for lesser word, you need the fix, you need the drug in order to get the psychological effect of having the drug, right? So that's dependence. Then there's something called tolerance. So if you administer, let's say, a drug that works on, all drugs work on receptors. So let's take the opioids, because that's what we're talking about. You give morphine a lot over a period of time. In order to get the same clinical effect, you'll need a higher and higher dose if you continuously exposed to the opioid. Now that depends on what's
happening with me at the moment.
So that depends on the dose, and it depends on the duration of time. And what you will find is you will reach a point where your side effect profile way outweigh the benefits that you get. So you get, because your dose has to be so much higher. The higher the dose, the higher the risk of you having side effects. So a lot of times, that's why I'm saying you have to find out what works for you, so that you know your big guns that you hold in reserve in order to sort your pain out. And then what you need to do is you try to get it for a shorter period of time, or you stop and give yourself a rest in order to reset your receptors, yeah? So yes, if you use increasing doses for a prolonged period of time, you do get tolerance. It's a normal pharmacological effect. That is just what drug pharmacology does. So yes, it is a real issue, and it can happen. But as I said, the bigger issue is underlying cause, stabilizing disease. Because you have to remember, this pain that you're feeling is a bad thing. It's compromised perfusion to organs. You're infarcting, you're stopping blood supply to whatever part of your body that you're feeling. So you might think it's pain and you're all right, but your organs on a cellular level could be compromised and could be dying. So it's very important that you have disease stabilization. The pain, as I said, is a symptom. And it's a life-changing symptom because it affects you. It has such a psychological effect, but you have to remember that there's underlying organ damage that can be happening. You have to stabilize your disease. Yeah, you're getting pain for a reason. Okay.
How long after paracetamol can you take tramadol or morphine?
Can you take?
How long after paracetamol can you take tramadol or morphine?
So, as I said, you have to be careful. Now, when you have the combination, paracetamol is a very safe drug. Once you don't have liver failure, liver problems, paracetamol is safe. But you're limited to about 4 grams in 24 hours. That's the safe dose of paracetamol, right? So that equates to 1 gram every 6 hours that you could take safely. Now, you have to be careful because the stronger drugs and more potent drugs are normally combined with paracetamol. So Tramadol is tramadol and paracetamol. So you shouldn't be taking Tramoset with paracetamol because you'll be taking more than your 4 grams if you check over the day. You follow what I'm saying? Yes. You have to take either or. So either you separate the drug and you take pure tramadol with pure paracetamol, which I highly suggest, highly recommend, because you could overlap the dose. You follow what I'm saying? If you take Tramoset, you might just be able to take that 1-3 times a day. Whereas if you take your paracetamol, you could take that every 6 hours, and your tramadol you could take every 8 hours. So let's say you start 6 o'clock in the morning with your first dose of paracetamol, 8 a.m. you could take your first dose of tramadol, right? So you have both of them working, because your next dose is due 6 hours after this, midday. You understand? But you already have your 8 o'clock dose of paracetamol, of tramadol working. You all following what I'm saying?
Yes, yes, yes.
Right. So rather than take Tramoset at 6 a.m. and then 12 a.m., right, with nothing in between for that 6 hours, if you take your paracetamol at 6 and at 8 o'clock you take your tramadol, you will have overlap of pain relief before your next 6 o'clock, your 6-hour dose of paracetamol. Do you get what I'm saying? Yeah. So you'll have 2 drugs working there, or possibly 3, because you could take a non-steroidal 2 hours after that. So you will have overlap, and remember, these drugs work differently on different pain pathways. So they don't tackle the same pain, the same way you perceive in pain. It's working on pain from different sites, different areas. Okay. So you get your timing, so you have a blanket of pain relief over the period of time. Because you won't
Tramoset without Grapol.
You could take Tramoset without Grapol if you're not sick. Only about 35% of the population will be sick with tramadol. Okay. Similarly with codeine, with Pathadine, it's a similar enzyme that gets induced in terms of you have a genetic predisposition for that enzyme. So the active ingredient for codeine is morphine. Codeine is inert. It does nothing. It's converted in your body to morphine, and that's the active agent. Okay? Yeah? Okay. So that's the pharmacology of the drug. So in effect, it's what it's metabolized to, and the drug and the enzyme that metabolizes is genetically predisposed for converting codeine. I'm talking about Pathadine and Pathadine F, if you're on real potent painkillers, right? And yes. The people who get sick are the people who acetylates quickly, and you'll find that those people tend to be drowsier, they tend to be more sick because they have a higher concentration of morphine because they metabolize the drug quickly.
Okay.
But the side effect of that is they get more side effects. Yeah.
Another question is, can hydration damage you in crisis treatment? It has been withheld, and I understand this because a couple of weeks ago, while I was on the ward, the doctor said he's not coming to put back an IV access, and he doesn't want me drinking any water. So I'm like, what?
No, that's now, I don't know your circumstances, what you came to hospital for, whether they were prepping you for theater, but even so, It would be more imperative for you to have an IV access.
Exactly. No, I just went in for a basic crisis.
Yeah, so I don't know who talking to you. That is real madness, and
exactly.
I don't know what kind of obia that is. That is real obia. and I do apologize. And despite all that, you make it out, girl.
No, yeah. But I told him, I said, no, this is the first time a doctor told me don't drink water.
Yeah, that's ridiculous. That is absolutely ridiculous.
So, Dr. Ventour, if I may, you mentioned that education is important for these physicians, right? Is there any way that you could assist us in getting that word out there to these physicians who are at the A&E department?
Yeah, definitely. I think it will be worth having a targeted discussion with my colleagues.
Yeah.
You know, because
that's awesome.
But I think it's everyone. That. I think it's everyone, because the issue is you might not like A&E, but I'm telling you they will be more keen to treat you than on the ward. The ward will be probably the worst because you get no treatment.
No treatment, exactly.
Yeah. So and then they wonder why, and then they keep you for 2 weeks. I'd never understand that. Why you'll keep a sickler so long in hospital? You a sickler, you want out of hospital. Exactly. You understand? You know, you have altered immunity. You know, you have no spleen. You know, you understand? You need to be out of that place ASAP. Anyway. But the ones that I see, unfortunately, are people in a lot of trouble. So the acute chest syndrome, people who are deteriorating because of severe vaso-occlusive crises. So I usually see you too late, I think, in the whole process. So I'm talking about your run-of-the-mill person coming in terms of your crisis, turning you around, getting you home. Yes, there is a big need for discussion with colleagues on wards and in A&E everywhere. And I think it's everyone's business. Pain control, pain relief is everyone's business. There's no...
So doctor, when you say use CBD as an alternative method, how should it be used?
Well, you see, it depends because it's hard for me to say use CBD. One, it's not legal here yet. It will be. The difficulties with it not being legal is that you can't guarantee the source that you're getting it from.
Yeah.
So if I tell you your formulation, you're taking 2 drops, you're getting 36 milligrams of cannabinoid, I can't guarantee that you get that from your source when you buy it over the internet or get it from Jamaica or wherever you're getting it.
Yes.
Because it's not a regulated drug. So all I will say is it's an alternative therapy and you use based on how they prescribe it. It's normally 2 drops nocte and you could increase the number of drops that you take and you see how it works on you. It's something that's not going to work immediately, but it has to accumulate a bit. So over time, you have to give it a few weeks and you see how it works, whether your sleep-wake pattern gets better, whether you find that your pain is a lot less. It just depends. And again, you stick with the brand that you get because you know that works for you. But in Trinidad, it's an unregulated, still not legal drug, and that's why we wanted to get legalized quickly so that you could, you know, if you go over the counter and you buy a gram of paracetamol, you know it's a gram of paracetamol. You don't know what you're getting from the CBD. You don't know.
All right, sure.
You get what I'm saying?
Yes.
Yeah. Any other questions?
Yeah. Someone asked if they're putting their body at risk by rallying out through the pain to avoid taking too many painkillers.
Yes. The issue I have is you're in pain for a reason. And you think of it that your organ is talking to you and saying, listen, I'm not getting oxygen. I'm not getting the blood supply. Something serious is happening here. And you need to sort out. So being a sickler, you know what your pain, you know what your pain range is because you live with this thing. So you know to yourself, nah boy, no. This is worse. This is worse. Right? You need to get help. You need to find the help. All we do is run tests to see what's precipitating this. And we run tests to find out what damage is being done. And those things, we try to alleviate the damage and we try to preserve the organs you have in terms of not having significant kidney failure, significant bowel failure, all these kind of things, significant strokes. So you have to be careful because once a sickle crisis starts, and you will know to yourself, no, this is worse than I normally get. Something's going on here. I think you need to get some help rather than tough it out at home and then you come into us with a stroke. Or you tough it out and then you come in with severely damaged kidneys.
But I can understand toughening it out than having to deal with them in the hospital.
I know. But while that might be okay with you, it won't be okay with your organs.
True.
Because you'll be left with a lot of damage that you could have preemptively sorted out, you know. Now, I'm not saying you run to hospital with every painful crisis. You probably will have a crisis, you know, every other day or every other week. But you will know when your pain is different to what your normal range of pain is. Sicklers know. They all know. No, this is no, I need to move, yeah? So I think, yes, we all don't dislike hospitals, but I do think there's a purpose for the hospital, which is underlying cause and ensuring that you have good organs, that we preserve your organs. The last thing you'll want is to be a sickler on dialysis, you know? Yeah. So
someone else, can you do some pain management classes with our community with the goal of members, teaching members monitored by your team?
Yeah, we could have some sessions. That's not a big issue. Also have some sessions with sharing, because sicklers have to help sicklers in terms of sharing what works, what doesn't work, you know? And this is a very good forum in terms of having interaction and having people share ideas and things that work in terms of alleviation of the pain. So yes, I'm open to help with sessions, no problem. That's not a big issue.
All right, and somebody also asked, can we request pain management professionals when we get to the A&E?
Yeah, you can request them, but whether they will know to call them is another issue. So we started what, a pain management team for the last, well, we put in COVID aside. COVID has messed up everything because we have no staff now. Everybody's going all over the place to try to help out with the war that's going on now. But pre-COVID, we had an established pain team in Eric Williams. And I keep telling you, I get referrals for pediatrics. I don't get referrals for adults, ever. They don't call. I've got a few referrals for the pediatric management, but I've never seen an adult physician call for pain management.
Oh, so I come to Port of Spain.
Huh?
I say you don't want to come to Port of Spain.
No, well, the issue is not the availability of a service. The issue is having the colleagues colleagues say. Yeah. So by all means, I think if you're there, you should ask. By all means.
For me, that is an issue not just with pain management, because even when we facing a serious hematological problem, they don't call the
hematologist,
the hematology unit.
Yeah.
Until you request it.
Yeah. No, sometimes even if you request it, because it happened to me.
Mm-hmm. Yeah. I'm glad Dr. Smith is on here as well.
All right, yeah. So I'll ask one more question, because I know you have to go and we want to allow Dr. Smith to
go. Sure.
Someone says sometimes you see patients when that get worse after not being treated properly on the ward, yes? And then okay, can pain be controlled in the A&E? Can pain be controlled in the A&E before before history, etc., pursued and overlapping modalities done?
Yes, the approach needs to be done from home. You overlap because you would have exhausted what the normal first tier is, which will continue in hospital, where you should be getting stronger painkillers. You get what I'm saying?
So what you were suggesting earlier in terms of using the
splitting
paracetamol and
the non-steroidal,
right?
short period of the
you
timing.
Should do that first.
Yes, the timing.
Right? And if that doesn't work,
stay well hydrated. You understand?
Yeah, but if you're doing that at home,
yes,
how long should you wait to say that it doesn't work?
Well, you are the expert in your pain. you have a high pain threshold. You know that this pain is different. So if you know the pain is different, you don't wait. You say, nah, boy, something wrong here. This is not what I'm accustomed doing. I need to get checked out. I need to go so and so. I pop a tablet in just to alleviate a bit, and you go and see what's going on. Yeah.
Yeah.
If it's normally in your zone and you have a flare up, well then you have time, you overlap, and you see how you monitor your pain and see how your pain go. You get what I'm saying? It's very patient specific. Yeah.
Okay.
Your disease and your pain is specific to you. So it's not going to be a ballpark. You know, if it doesn't work in 2 hours, you need to get to hospital. You might get up in the morning and the pain is severe. You have an acute ischemic limb. You don't know that. Yeah. You just know this is real severe leg pain. Oh my God, it's the worst. You need to get that checked out. You're not supposed to stay home and be popping tablets and want to control that. There's something serious going on. So that's what I'm saying. You need to know your range, where you function, and out of that, you need to get help.
Now, I know we have some patients who experience chronic pain and they're on morphine at home, like, and they may be using liquid morphine or other types of morphine. Sure. And they complain a lot about the itch and those side effects. What can they do for that?
So the thing that helps a bit is they get a bit groggy. So Piriton helps.
Piriton doesn't help anymore. I'm scared of my perspective. Piriton doesn't help.
Yeah.
Pistol, all those things. I recently, somebody recommended Benadryl.
Yes, Benadryl is quite good.
Tried it, but it's not like, you know, it's working, but it's not working great.
Yeah. But it all depends, because that's a histamine release phenomenon, you know. So the whole goal, as I said, if you're on chronic morphine, is not to stay on chronic morphine.
So what about fexofenadine?
Yeah, fexofenadine is another antihistamine. So you could try different antihistamines and see which one works. The reason why the Piriton and stuff works, they all work on the same receptor. But why Piriton and stuff works is because you sleep. Now the itching will be an agony because you might have pain control in the night, but you're itchy, you're still casting. Right? And that's why the drowsy antihistamines are very good at night. You know, you take it. But what I keep saying is, all the drugs that you use come at a price. Yeah. Nothing's for free. Right. They have drug interactions, they have side effects, and nothing comes for free. So what you have to do always is to come down to the lowest baseline drug, even if you're on chronic, that you could function with. When you're in a chronic pain syndrome state, you're not going to be pain-free. You have to get in a range where you could function, yes? And when you're out that range, you know something else is happening, or when you're out that range, you need to get sorted in terms of disease control.
Okay.
But this is what happens when you're in a chronic pain situation.
All right.
I have one more question.
Yes.
Before you leave. Well, this is from me personally. Right now, I am treating 2 ulcers from IVs. One on my thigh, one on my elbow. Yeah. And nothing is working orally in terms of Zinat, augmented, nothing. My private doctor started Ceftriaxone. This is my 3rd day of the injections. And it's still not responding to it. It's painful, it's irritated, it's everything.
So it's a couple of things. Is it infected? Because I see they're treating it with it is infected. Have they swabbed it?
No, they haven't.
Right. So how you know what antibiotic to use? It has to be swabbed. Yeah?
Okay.
Yeah. So if the ulcer is swabbed, it needs to be swabbed for them to know what bacteria is there. And then you put a specific antibiotic for that. Otherwise, you're just driving resistance.
Yeah.
Because if you're treating it with a bug, you're treating a bug with an antibiotic that nobody knows what the bug is, and it's not getting better, you're driving resistance. So by the time you come to hospital for it, we have no antibiotic to treat you.
Oh.
You understand?
Yeah.
Yeah,
So,
I do.
so you have to be swabbed. They have to find out what that bug is, because I don't know what it is. They then have to make sure that the infected ulcer is not down to your bone and you don't have an osteomyelitis, which will keep you in chronic pain with chronic infection and have you in crisis all the time, damaging all it.
It's constantly irritating, constantly.
Right, which means that you may be bacteremic, you're having an infection going there. It's not sorted. So you get what I'm saying? The underlying, yes, the underlying problem needs to be sorted out. So you have to insist that you need a swab. It's not getting better. And 3 doses of IV ceftriaxone.
Not IM. They don't want to hook up an next IV have another reaction.
Well, when I say intravenous, intramuscular, administration should have started to, you should have seen that drying up by now. So I really do think you have something quite resistant there, or you just have something, you got it in hospital, right?
Yes, I did.
Yeah, so it
might be the reason I don't want to go back.
There might be Pseudomonas there and those antibiotics won't touch that.
Okay, Dr. Ventour. This has been very informative. I know you have your own engagement to go to, and there are a lot of questions. So I know people have been enjoying it. So I think maybe we might have to have a part 2 at some time.
Yeah, no problems.
Okay, right. So I think that's something we could arrange for future, but I'll give Dr. Smith chance to go on so that you can attend your meeting. But thank you very much. Thank you very much for your information and your knowledge shared. And I'm sure that you've been very helpful to the attendees here, right? I know we could go a lot longer. But
yes, thank you. It was enlightening, Dr. Ventour, and I hope we could have future sessions with you.
Yeah.
Yes, it was.
Yeah. Okay, Dr. Smith, welcome. Thank you. Right.
Dr. Ventour covered nearly everything. Practically everything. The only thing I'd add for Alexandra in terms of you have to start with our 1st generation and 2nd generation antihistamines, of which the diphenhydramine, the chlorpheniramine, which is the Piriton, 1st generation. So they cause sedation. But the aim is when you take morphine, you try to take it before you take the antihistamines, before you take the morphine. Or the histamine will release, and then it will make no difference. You'll be scratching, and then you'll have nothing to cause the blocking to occur. Right? Of the best, as I said, Allegra, fexofenadine. You could take that at the doses 180 milligrams orally, and it's because the 2nd generation lasts for the entire day.
Right? Yeah, well, today the doctor gave me Allegra because the ulcers as well around them, it's irritated and itching and red and I'm going mad.
Right. But that is also one of the part of a bigger problem. The bigger problem is that we're talking about so far is 1, treatment at accident and emergency. 2, a dedicated pain management specialist in porous pain and probably mounted for the adult population. 3, we have to find a way for people who have difficult accesses to get access to central access fast.
Exactly. Yep.
Right? So that it doesn't be able to end up in a situation where they're trying to find some sort of vein that's not going to have any much benefit for you in the long term. And then you get ulcers happening because you had one on your finger that healed, and then you have one in your leg and one in your hand.
And one in my arm,
and one in your arm, where if they had put in a central access, you might have avoided that because you're known to be a difficult IV access.
Yes.
Those would be difficult, very difficult to implement.
So since she's a frequent hospital visitor now, and I know this is not commonly used in Trinidad, but would a portacat be a benefit to somebody like her?
Right. So portacat is very challenging. I had other patients I tried to get a portacat for, ordered it from away in America, brought it to Trinidad, trying to get the portacat system. Well, first off, the answer is yes. I would advise anyone who is a difficult IV access to get a portacat in administration of pain medication.
Yeah.
And I've tried it myself. It is very, very difficult to get a portacat. So even if you get the portacat and they have it in their hands, and they're bringing it to you, you still have to get a surgeon to place it into the subclavial artery.
And they said it's prone to infections as well.
It is prone to infections, but remember, with everything, you have to weigh the benefits versus the risks.
Yeah,
exactly.
Right. So it's a choice. Everything has benefits versus the risk. So then, Alexandra, in your case, if we don't give you a portacat, then every time you come into the hospital, it will be hell.
Yeah.
Every time it's a fight to get your essential access. A lot of refusing along the way. A lot of refusing to give you pain medication because they find it not easy. A lot of injections, and people tend to not be very forthcoming in terms of giving the medication to all patients with sickle cell disease because of the fear people have of opioids. Yeah. So if I can have you coming in with an access ready and available, I will have more willingness from people to administer medications.
Yeah.
Right? Yesterday, there's a chance of infection with everything else because we're installing something into the essential vein. Most times, it's in subclavia. But it would be advised. The problem is installation and getting a surgeon willing to install it. Yeah. Because, and it goes into the one, number 9, not number 9 in terms of the question, let's say, where you ask if, number 6 actually, can home use, can clients or can patients who suffered sickle cell disease, can they be trusted with using strong medication? And we have a fear in Trinidad and the wider population of all opioid use in anything intravenous. And it is seen in countries where we have the freedom to give intravenous medication. We see abuse and we worry about abuse. America has an opioid crisis for that reason, although it's kind of more because of oral medications than anything else.
Yeah.
So we have a fear of giving things intravenously, even if it was to save a life, and people don't quite understand pain because pain is subjective. It is your experience, not the experiences. So sometimes you can't tell by the vitals, you can't tell by the blood pressure, you can't tell by the pulse, you can't tell by the person's face, especially if they're getting pain for a long period of time, right? So because you can't tell, people have their own opinions of whether you're in pain or not. So they'll watch you and they'll determine based on how they believe you are experiencing pain, and they will determine how much medication they should give you. So even if I write for a large dose of opioids, I will find that I might get quarter of the dose because someone is afraid. And that doesn't apply.
Afraid to give it.
They are afraid to give it, or they'll come and they'll have their own perceptions of how it will work. They're not going to give this amount, they're going to give this less few. Yeah. So there's challenges in terms of education. There's challenges in terms of the assets. I believe it would be good to have patients be taught how to, what medications to procure and how to be taught to give it. But there's difficulty and worry about abuse. The second thing is that we talk about opioid dependence and opioid tolerance. Dr. Ventour covered it marvelously. And one of the things when it comes to pain is that you cannot determine someone's dependence on opioids if they are in pain. When you're in pain, you cannot really be dependent on an opioid. You can only assess that after the crisis has passed. However, it is noted though that if I give you opioids for 5-6 days on the ward, you will develop some sort of tolerance to it, and you may develop some dependence on it. And because of that, the latest guidelines state that you still continue giving opioids even after, and you slowly down titrated so the body doesn't have that physical dependence to it. You cannot control that dependence. If I give you opioids for 5 days at a time and I stop it suddenly, your body cannot help not getting that pre-fit, so you should slowly down titrate it to prevent that from happening.
But does it even have to be so often, or could you grow out of it as you get older? Because
no.
I recall, the first time I received Pathadine was after my stroke. And I was still getting headaches, right? My brain was swollen. right? You know, at that time, I got the high and the pain left and put me to sleep, all kind of thing. But the last time I got Pathadine when I broke my ankle, they gave it to me, but I didn't fall asleep and I was still in pain.
Yeah, that happens to me a lot.
You know, I might have felt the drowsiness, but it didn't put me to sleep.
Yeah.
You know, but you know, the pain is still there. It wasn't really effective for the pain.
Could
You
I
know,
share
so I don't know
one
if it is
time?
that as you get older, you grow out of it.
If I can share, I always, all throughout when I used to have bad crisis and had to be hospitalized, this is like probably more than 14, 15 years ago. And I would always receive morphine and it would work for probably a couple hours and I would sleep and, you know, then I'll wake up in pain.
You get up and you're in pain.
Yeah, but then the thing is, at one point I was prescribed Pathadine to take home, but Dr. Waveney Charles said, do not take that. So that is why I always have this fear of, I hear this widespread use of Pathadine, but I understood what Dr. Ventour was saying about, you know, the main goal is to get rid of the pain and wean it off, you know, use the short bursts of these kind of drugs and then wean it off with you know, get off of it. So I don't think this is happening in the hospital. So I wish that we could increase this education about the proper use of these
how to
drugs.
prescribe opioids. Now, here's the thing about, I could share my experience with using Pathadine, the very, very bad. That is why I'm a bit afraid of it, and I could share how it's supposed to be used. Now, with regards to morphine only lasts 4 hours in the system. And that is the biggest problem that I have when I have to change over when I'm actually cold. Because they don't really call us so much. When I'm actually cold, is to change the morphine frequency. The issue is not only frequency and dose, but the issue is frequency. Morphine only lasts 4 hours. So if you're not mindful that morphine only lasts 4 hours, and you give a dose of morphine every 6 to 8 hours, it means that this person is going to go to sleep comfortable for the first time in a while, because morphine works very well for pain. And after 4 hours pass, the pain will just start to pick up, and start to build up. And they'll get no pain medication because the nurse saw that they're supposed to get medication every 8 hours. So I mean, for 4 hours until the next dose, you're going to be in pain. The next issue that you're going to expect is that when someone now comes into hospital, you don't know how much morphine to give. It has standard that you would know. So it has something called breakthrough pain. And you're supposed to prescribe a second dose to give the person in addition to the dose of morphine that you give them initially. The issue it has there is that even if I write it, unless I am physically there to come back and review, that breakthrough pain medication is going to come. If you've been on your ward and I have to manage it, you will know that I'll give you an IV dose, a medication, and I'll also have the liquid there to give for additional pain that you get. So that you'll get that medication.
For me at a time.
Yes. That's probably the time you actually see one in the ward at any point in time. But they give you the IV dose, that will give you the pain control. And if the pain medication starts to wear off or starts to go down by the third hour, they get the oral dose to pick back up until they get your actual dose in 4 hours time. It gives good pain control. And what I could do from that, so because I know, okay, here what the breakthrough dose is 5 milligrams, and your dose is 10, I could increase it to 15. So you'll get a stronger response for the entire period of time. But you have to be aware that morphine only lasts 4 hours. And that is the basics that if it's not known, you'll see a lot of hell. Whether you go casualty, whether you go on the wards, you'll see a lot of hell. That is the morphine issue. This issue with Pathadine now.
Then doctors, they refuse to call you too. It happened to me already with you.
Yeah,
I've requested many times and they say, yes, I know Dr. Smith is your favorite. And it's like, it has nothing to do with that.
guys, what the next issue is with Pathadine. So Pathadine lasts 6 to 8 hours, just like tramadol, right? the issue is that Pathadine, when it breaks down, and I could go into the pharmacogenetics because I see that it was requested before. With Pathadine, it breaks down into norpethidine, and norpethidine lasts 18 hours. And norpethidine stays in your system for a very long time. And I mean very long time is 24 to 72 hours. So you get one dose of Pathadine, you feel good. It don't do for pain, but it will keep you a bit drowsy. You get a next dose, it building up, right? You get a next dose, it building up. That is on your side, but you keep requesting doses. These receptors that Pathadine acts on isn't really the pain receptors. It acts up more on the pleasure receptors more than the pain. So you don't really get that reduction of pain. On my side, what happens on my side is that your kidneys start to fail. So if I take serial blood tests during the time that I take in Pathadine, I start to watch your kidneys start to fail. And I had bad experiences where the patient's kidneys fail out completely, and I had to carry them to our version of Ventour to get put on dialysis.
Right.
And the kidneys never return to normal. And when the kidneys never return to normal, the kidneys are responsible for the blood that you produce. So it's going to be a bad feedback cycle, right? I had patients die as young as 20 because the doctor was using Pathadine because the Pathadine was working because it lasts for 8 hours. When you end the pass away at 20 because the kidneys fail. From the very same thing, when your kidneys fail, when you come to clinic, your steady state becomes 4. I said it becomes 3. You might walk around, you might be fine, but I might see you one day, and then after I don't see you again, and I call on the phone, and it says, well, you know what, he passed away. And when the kidneys fail out, they don't produce enough blood, because kidneys is responsible for a hormone called erythropoietin that stimulates the production of blood. So your steady state drops from the 8 it was, or the 9, straight down to 4. I can't give you hydroxyurea. Right? Because that will make a bad situation worse. And then from there, it only has downhill to go from there. So my fear of using Pathadine is part from I know what it does. I know the neurotoxicity. I know how it builds up in the system. And part because I saw the effects myself in terms of the lives of patients afterwards. Yes, your crisis has been averted. Yes, you'll get better pain control. But then after, when you come and pay clinic visits and you check your counts, I tell you, well, here what in your kidneys is feeling. And I don't I'm tend to mince modes with that because I worry about that a lot. So that is my reason in particular. I haven't got to experience anybody with severe neurotoxicity. They did get seizures, by the way. So I did get patients with seizures from taking Pathadine. But nothing significant. It didn't go further than seizures. But by that time, the kidneys had always also failed out. So one or the other, I could have caused it.
No. As you mentioned, kidneys there. I just want to ask something for pain management for a second. I know when we do our blood tests, we see a liver function test and a kidney function test. But is that those tests in itself, by themselves sufficient to really monitor the health of your liver or kidneys?
It's sufficient to monitor the health of the liver, but it's not sufficient to monitor the health of the kidneys.
Okay.
The liver function test, because the liver produces the majority of the enzymes in the body, the liver function test tends to be a large panel and it tends to be all encompassing.
Okay.
The kidney function test, the blood test is not really that sufficient in terms of telling minute kidney damage just happens after getting crisis or repeated crisis events. Okay. What you tend to have to do is you have to go and check the urine and check to see what is the flow of urine and how much protein is in the urine, because your body tries to conserve protein. We know from sickle cell nephropathy, we know what happens. The first thing you have is hyperfiltration, where your kidneys seem to be working very, very good. So if you check the blood tests, you look at the bond and the creatinine, and normal creatinine going to be between 0.4 and 1.2. Someone suffering from sickle cell disease, their creatinine tends to be 0.3, 0.2. Hyperfiltration, it works very good.
Okay.
That's the first stage. After that, it tends to not work as well.
All right, so that's where the that would require what, a simple urine test, or that's where they do 24
that requires 24-hour urine test actually. Okay. Right.
And how often should a patient do that?
That should be done on two things. If there's evidence of a change in renal function from the baseline, so if when we check the blood test, there's a change in function or the urine sample. Other than that, it will happen at a yearly basis. If there's no change in the blood, there's no real need to go and check a more sensitive test looking for a minor change that you can't give any medications towards. Right? Let's see. Body pain receptors. I think that Dr. Ventour answered this question. As you trust the sickle cell community, you know their pain type can this be taught or legislated. The legislation part will be tough. Changing any legislation requires a lot of politics.
Yeah.
Not on our side. Yes. Yeah. As you're working through to fight for more things to be given to patients, you have to face. It's like playing a game, like playing that. So something that face numerous levels of resistance at every level.
Ministry to do a cabinet note, and that cabinet note could sit in cabinet for weeks or sometimes months. And even if it gets approved, reaching to parliament takes longer.
So you're in trouble. Legislation is difficult.
Yeah.
To get legislation pushed forward, it's always best to have someone on the board and the ministry held directly advocating to get something done.
Yeah.
That'll be difficult. Now, can a person's genetics be studied to determine what pain medications to give? Now, it's been studied already, the pharmacogenetics with pain medications. One with hydroxyurea and one with opioid use. Well, we're very familiar with opioid use because there are CYP enzyme systems that are responsible for opioids. And depending on how fast you break it down, the opioid, determine how well it lasts. The next is for hydroxyurea. Hydroxyurea has about 4 drugs that they identify, 4 genes, that they have identified that respond, that help with the development of the red blood cell. Because the issue in sickle cell anemia is the red blood cell. And as you know, hydroxyurea works to increase the fetal hemoglobin. The red blood cell, however, in the development stages, different genes influence its makeup. So some people, especially those in the area of India, they tend to suffer from thalassemia as well. It is noted that their red blood cells have a higher fetal hemoglobin production, even after birth, and they're supposed to produce adult hemoglobin. So it means that if you use hydroxyurea, you have a bigger benefit in this population. And then with that, you could figure out who could benefit best from hydroxyurea, and then you could figure out how we could benefit best from opioid use. The thing is that genetic tests tend to be expensive.
Yeah.
And then you need to have geneticists. We have only one geneticist in the country based in Port of Spain. And the majority of times you have to go and for her to actually work, she has to get all these test panels from abroad, which is expensive, time consuming, has to be kept at cool temperatures, cool storage. So by the time it reaches here, it will just be too expensive to actually carry out. And on top of that, it needs to be made a policy. So that will be a bit difficult. So the question is that it could be done. You can determine the person's genetics, but for you to really do that, you probably should be living in Dubai. I'm not sure that the chances it happening might be low. Let me see this one. Sunlight and warm water therapy assists venous health. Venous health and its subsequent ulcer therapy is very difficult therapy. The public hospital sector does not provide the range of medications required to treat an ulcer. So it is difficult to do long-term ulcer care with just the management from the hospital. Our medications consist of medical honey, which is called L-mesitran, fusidic acid, which you may call fusidin, and dressings that has either or. That is really bacteriostatic, but ulcers require two things in terms of healing. One, it has to have an absence of bacteria to stop.
You stopped hearing you, Dr. Smith.
I wonder why. All right.
Okay, good now.
All right, good now. Okay, good.
What are you trying to censor about?
Oh. For treat ulcers, we have two things we have to take. One, we have to make sure it has no bacteria that is not pathogenic that are going to affect the tissue. That is one. And two, we need to also be able to help with stimulate growth of the tissue. In patients with sickle cell disease, we don't have some of the modalities that work quite well, we don't have available. Sometimes you could inject a medication called filgrastim to help to stimulate growth. We can't do that because it is known to cause crisis in patients with sickle cell disease, immediate crisis at life-threatening. So we can't do that. You could I could take some of your blood, spin it, take out some plasma and inject it into it. That's going to work well. Right? You call that platelet-rich plasma, but the facility is not available to do it in the public sector. The only facilities I have available is cotton, bandages, and to wrap the area, and probably give you some antibiotics. So I don't have, at least in the public sector, much tools available in my arsenal to which to treat. And it have a wide range of dressings. We have a wide range of dressings I could use, but not available in the public sector. Okay. So ulcers are very difficult to treat. Warm water therapy, no sunlight, no, they don't make much of a change in terms of venous health. What could be done if the veins have reflux? One, you can identify the veins, which requires an ultrasound to identify the veins that have been bad. And you can't really repair those veins once they've been bad. So what we do is that we ablate them. We inject it with a dye. I don't suggest any surgeries to anybody. No surgeries in your legs because that would just go from bad to worse.
Yeah.
Inject it with a dye to block these bad veins, stimulate blood leaving the area and promoting healing. Right?
But even if the ointment's not available in the public sector, what are the ointments you would recommend to persons?
All right. It's not ointment, it's the type of dressings, right?
Yeah.
So for me, ointments don't, in my personal experience, trying with venous ulcers, because there's a lot of patients in our clinic with it. The ointments don't work well.
Okay.
You adjust what happens. I get a perception that it works. The patient gets a perception that it works, but they come back months, years with the same ulcer, and I can tell that this is not working.
Yeah.
Right? So what I suggest some dressings. I'm gonna see if I could type it.
Could you get that in the pharmacy?
I tried.
Without a prescription? No?
No. It's just not available. There's a lot of problems, even.
Yeah, we're not hearing you again.
For real? My headset. Oh yeah, typing. That helps the situation. That helps. Right. What else I could
Dr. Smith, select when you're chatting, right above you'll see two select panelists and attendees, so they will see it.
Oh, okay.
They didn't see that last message. Yeah.
Oh, okay. My bad.
So my thing is, you're putting it there, but how are we getting it?
Right. So if I could, the only way to get medications, you could still get medications. All medications could be acquired. But the only way to get medications, what I do for patients in the clinic that can't acquire medications here, is that you buy it from abroad. Most times buy it from India, and you ship it down from India to here in a large number. If you know you're going to have an ulcer, and that ulcer is going to go away in 2 days, and not going to go away in 2 weeks, an ulcer really goes away in less than 3 months. Any ulcer. So you need the medications. You order the dressings from India Farm. You get a prescription if necessary. Sometimes they don't need prescriptions. And you order it from online, and you bring it down. If you attend a clinic, let's write a letter saying, well, you know what, prove that you get this medication, and you collect the medication from right next where it's called this food and drug production is around King's George Park, and you collect the bulk of medications from there, and that tend to be it.
My next question is: are you back in hematology?
Actually, I'm seeing 2 to 3 deaths a day for COVID. No, I'm not back.
Oh, okay.
So,
Exactly. So how are we getting to you? Exactly.
In these formers.
Yes, I've been getting both every time I go clinic.
Again, I find blame for things. Yeah. Let me see some other questions I could answer. Have they seen opioid abuse in sickle cell patients and share that? No, nobody seems to research it. Nobody seems to do much research. We don't tend to do research much anymore in terms of sickle cell disease at this moment. So I can't say that because nobody seems to study it. Notes is very
Yet they all believe that all patients with sickle cell
but people come with their own suppositions
are addicted.
And they come with their own beliefs. So, and that it's difficult to tell somebody who might be older than you, especially in my case, because I'm a young doctor, so you'll write it down somewhere there, how to manage something that they have been doing for a while in a certain way, and they believe it works. Especially when they're the ones with the medication in hand. So does your blood count decrease as you age? Steady state was 9.3 and after 50 is 8.7. Your blood count didn't decrease, but production of blood does decrease as you get older. And the reason that it does decrease is more because of hormone production. So that at a steady state it decreases is that 1, blood production decreases, and 2, in your case, I should add in that these cells don't live as long as they used to, especially sickle red blood cells. What would you suggest as a home pain remedy for priapism? Well, that is very serious. For acute, in the acute setting, priapism has to be one of the most debilitating conditions that could for a man because you only have 4 hours to correct it. If it lasts for more than 2 hours at a time. I suggest pain medication, but I really, really would like you to get this checked out immediately because you will lose the opportunity to have an erection. And I don't like that when that happens at all. And if you don't lose, it's very difficult for you to maintain an erection. So this is one of the conditions in which it might seem embarrassing.
All right, Dr. Dr. Smith is a little frozen. We'll wait a little bit until he comes back. Yeah.
I see, in the meanwhile, I see Nadia has her hand raised, so I will allow her to.
Okay. Yeah.
Oh no, he's back.
Yeah. All right. Dr. Smith, what you could probably do is you could take off your camera to still frozen.
Nadia, in the meanwhile, what you wanted to say?
No, I was just about paraprism. We had an instance where a child was about 7, and he was quite, it could be around 7, 8, because he was quite embarrassed to tell his mom that he had that issue. And I think the mom saw him in pain, and she asked what happened, and then the mother saw it and then brought him into the emergency. So from that, we started doing teachings with the parents and the children from an earlier age, because to me, I thought it was more or less in the preteen, adolescent age group. But having seen a 7-year-old, and even then they had issues, body image issues, with him not even feeling comfortable to tell his mom what was the issue. So I think education to all age groups about paraprism and the importance of it would probably, as you say, alleviate that that disability or problem that they may have further on in life.
Yeah, well, Nadia, I will say that you should try and encourage all your pediatric patients to tune in the morning to reproductive health with Professor Asnani, because some of those topics will be covered as well.
Okay, will do, because I did send out to a lot of them, and some of them are on today and was yesterday as well. So right, I'll do that tomorrow as well.
Sure.
And thanks, Dr. Smith.
Yeah. He came back just now. He probably having some internet trouble, so let's wait and see if he comes back.
In the meanwhile, that suggestion Dr. Smith made about the dressings, maybe it's possible that multiple people who have ulcers could come together and see if they could order it.
Yeah. All right. No, as the doctor mentioned, it requires some approval for the Food and Drug Administration to receive it. So probably they could do it with the assistance of the society. It might be easier, especially if they do that as a group and they come together to assemble the funds to purchase it.
Yeah, I was going to say that if it could be done through the society.
Yeah.
Okay, that could be something we could explore. Yeah. I think he's joining.
Yeah. Okay,
I'm back.
Yeah, I think Dr. Smith is back, but doctor, you can leave your camera off, especially if you're having internet trouble.
Oh, okay.
Yeah.
I'm back.
Yeah.
Any questions? Oh, my question. Let's blank. Well, look at that.
I think we were discussing the question with paraprism.
Right. For paraprism, I would like that person to get treated or seen immediately. Paraprism tends to have long-lasting effects, so it's not just the pain I'm worried about. That is one of the conditions in which end organ damage tends to be significant and happens quite frequently. And losing the ability to have an erection, whilst it might be embarrassing to go to the hospital, is something that requires immediate correction.
Yeah.
So yes, pain control is important, and we will follow the same routes in terms of pain control. But this is something I'd like a urologist to see you for.
Yeah.
Right? Because I want to know if this is something that needs to get drained. So it's something I want to see immediately. I'm not seeing any questions anymore. I think I escaped the panelist section.
Oh, probably because they were there before you joined. That's probably why. So somebody asked if we will see you in 44 again.
Oh yes, as soon as as COVID is no longer a big issue, hopefully, and then I could make a move back to 44. But really, I left because that is where I was the most at the point in time I left to COVID. I was one of the few doctors that was fully vaccinated, and I was at the height of the second wave, I should call it.
Yeah, yeah.
So that is where I think I would have best been needed at that point in time. So I went across.
Okay.
So as it's sorted out and things start to die down, I could come back across the 44. I'll sit down in Dr. Charles' chair for a little while again. That was a comfortable chair.
Yeah. I hope and pray it's fast enough.
Okay. I hope and pray for that too.
Mm-hmm.
Too many lives lost. You guys got vaccinated,
all right?
right?
I think we have a hand up just now. Just so. All right, one moment. You say you had your hand up, you could go ahead.
Hi, good afternoon, Dr. Smith.
Good afternoon. Good afternoon.
My son has sickle cell disease, and he had an issue with priapism. We went to the hospital, this is Mount Hope, and told them what it was and waited a couple hours before we were taken inside, and then waited a little while inside. He was given drips, some pain medication. We sat there for about 2 to 3 hours, and they asked, okay, did it go down? Well, she examined him. It went down, and the pain subsided. We were sent home, given a letter to go to urology, and we're still waiting to go to urology. For appointment for urology, and we're still waiting for that right now.
Okay. So.
And this was last year.
Okay.
It was last year or early this year, January or some kind of thing.
Son has the
Actually, no, I could tell you when that was. It was November, early November.
Okay.
Last year.
So if things taking a long period of time, but sadly, I was very sorry about that. But one of the more difficult things I have is that some of the complications of sickle cell disease are not beside the vaso-occlusive crisis. It might not be well understood at the level of accidental emergency. So you might not get the ideal treatment all the time. What I do suggest is when you get the priapism, he has to come to a hospital. The issue at that point in time is to go to the urologist for them to see if it needs to get injected or not. So sometimes we take a needle and put it into the head, through the head of the penis to drain all the blood. The next next medication that we could give to try to get the blood to come to leave the penis is nifedipine. It's a cheap medication. It's common to drop pressures. It normally takes half of a tablet at the point in time to help to reduce the priapism at the point in time. We hope with the pressure drop, you also have a drop in the venous return, and you lose some of the blood that is in the head of the penis. Take a visit to Ward 44, because what I do normally, because I was trying to remember, because I remember another patient with priapism actually brought another patient so I could give them the same medication, what to do when you have it. I actually give you the prescription for the medication for about 6 months. You know when you get it, this is the medication to take.
Okay, because he had a issue last week, but it wasn't very hard. It was just a little step and a bit painful. And he used ice and it went down and the pain went. But after reading about it, they said not ice, warm.
Warm, not ice.
Yeah.
Because ice will make the blood stay in the area.
Yeah. So, but it wasn't that bad. But because haven't been dealing with it for a while, we monitor to see when it's really necessary. Haven't had gone to A&E, and by the time you sit down waiting, pain gone, stiffness gone.
Yeah, but the thing is that when it happens repeatedly, my worry is that the veins get damaged. Lasting damage. And lasting damage is my worry, so it's my biggest concern. So yes, it might go down, but then what happens when it reaches the point where there's so much damage to the vein that it doesn't happen. Priapism is solved, but as a side effect now there's erectile dysfunction. Right? So I'm trying to avoid that from happening.
So how do you avoid it from happening?
Well, I write down the medications they could take. On the event it happens, you could get nifedipine over the counter.
Yeah, my mother is on nifedipine, so.
She takes 20 milligrams. Hey, you still buy for him, huh? Try still buy for him separately.
No, I'm just saying that I know the medication.
All right, cut it in half. And on the event of a priapism, he takes that. It reduces the flow of the venous flow, increases the venous flow out, and that's what reduces the time that he has a priapism until he can get more urgent medical care, because it mightn't be something that don't readily know to give at the level of casualty. And nifedipine at that dose is not doesn't cause significant hypotension. The blood pressure doesn't drop or tank with 10 milligrams of nifedipine. And given that it is difficult for me, I would normally not type down something like that on a public forum. But what I'm more concerned for his life, especially if he's waiting casualty and no medication is given to him or no extra care is given to him, especially in this time of COVID.
Oh, well, no, we haven't gone to that was in COVID because that was just earlier this year. Yeah. I left there sometime after 11 or something, so that night.
I'd just like to add, generally, it would not be feasible in all instances for everyone, but if there is something that you're dealing with that needs to be dealt with urgently and you need to get certain tests done and it's taken ridiculously long at the public institution, please try to get it done privately and get the results back to the clinic or whatever, instead of waiting and deteriorating. I'm sorry, that's what I tend to do where I can.
Yeah.
If possible.
Which is what we eventually did with him. We took him to a private urologist and all of that.
Right.
he said there's a buildup of calcium in one of the veins.
Because I hear horror stories like that a lot, where you're in the hospital and you're waiting on this test and you can't get results, or you needed to go and do this procedure and you can't get it done. But you know, sometimes you just have to bite the bullet and consider doing it privately, because otherwise you will deteriorate.
We are just waiting on the first visit to the clinic.
Yeah, as simple as a blood test, and they do have some reagent or something. Go and get it done privately and carry results back to the clinic. Because
all right. Dr. Smith, Karen says thank you, doctor, for your service to COVID-19.
Oh, no problem, no problem.
Oh, definitely. Yeah.
It's not a issue.
So I believe we could wrap up now. We've gone beyond time.
Unfortunately, we've reached 5 o'clock. You know, so, but it's been a very this has been a very informative, very interesting session. And we spoke a lot about pain management, but not just pain management. We spoke about a few other issues. But definitely, it's been a quite informative session. All right, we thank you for your time.
Yes, it's no problem.